This meeting is now being recorded.
Oh, good afternoon, everyone. I'm Dr. Jim Hudson.
All guests have been muted.
I work at the Pain Center at Mary Free Bed, and I did give a webinar last week, and some of you may have been there and some not, but I'm going to, just for the process of elimination, I'm going to assume that you don't know who I am. So I'm here with Melissa Litterdale, who is a pain psychologist with our program at Mary Free Bed. I am the medical director of the Pain Center at Mary Free Bed. I am a family physician by training, and I've been working at Mary Free Bed on a part-time basis initially since 1982, and since 2010, pretty much full-time work in the treatment of chronic pain, headache, fibromyalgia, and complex regional pain syndrome. There's some of my declarations there. And Dr. Litterdale's. We're going to talk today about headaches. Let's see where we are. And we're going to talk about difficult headache patients, because the easy headaches patients are easy, and probably all of us are easy headache patients for the most part. There's a couple of concepts: cortical spreading depression, which we'll get into, and central sensitization, and we'll differentiate those. And we're going to talk about what can you do to help someone who isn't responding to usual care. All right, so let's talk about headaches. 46% of women and 38% of men have episodic tension-type headaches. That's the ETTH. Episodic headaches, those are the typical headaches that are very common. 17.6% of women and 5.7% of men have migraine. And 4 to 5% of the general population have what we call a chronic daily headache. Half of those have severe daily, a half a percent. So, 10% of those have what we call severe daily headache. But when you look at headache clinics, so clinic-based studies, that's a headache clinic, 80% of the patients in the United States at headache clinics have chronic daily headache. So those are getting at what the difficult headache patient is. The International Headache Society classifies chronic headaches in various ways, but clinically it's not very useful. What that classification is useful for is in research, because if you're going to research treatment of migraine, then being very careful about the diagnosis is important. Most headaches, like I said, are easily treated. Most patients who have headaches, which are almost half of, actually when they talk about people having a headache, something like 80% of people will have a headache sometime within a year. But again, most of those people don't seek treatment for that. Maybe they had the flu and had a headache, or they got hit on the head and had a headache, or something else. And so mostly we just treat ourselves for that. Over-the-counter analgesics and combination headache medications work for most patients. When you look at medications to abort a headache, that's something that you take when you have a headache. And for migraines, they're dihydroergotamine and triptans are the two types of medications that are really pretty good for getting rid of a headache within a 2-hour span for most patients. We then have what we call prophylactic migraine medications, which is something that you take every day so that you don't get so many migraine. And we're looking for a 50% reduction in headache days to be successful, and we see that with both topiramate and propranolol, although that does vary with some studies. Whereas actually 23% of people who take a placebo will also notice a 50% reduction in headaches, which tells us something about pain in itself. But anyway, we do have effective medications, but they don't work for everybody. Chronic daily headaches are defined as greater than 14 days a month. When I say that these, and this is from the International Headache Society, when I say that these criteria aren't that useful clinically, because what if they have 13 days? Do you treat them any different? You know, again, you wouldn't use them in a research study, but you'd probably treat them the same way. A lot of these chronic daily headaches have been referred to as transformed migraine or chronic migraine, and the official classification changes from decade to decade. They've been termed variously, any one of these. Chronic tension type headache, again, would be a tension type headache that occurs more than 14 days a month. There's another thing called a new daily persistent headache, and that's someone who starts having headaches every day, 24 hours a day, 7 days a week, 365 days a year, and it begins within a 3-day period. These are not extremely common, but in my headache clinic here, we certainly do see those people that never had headaches before or had headaches, occasional headaches before, and then they can tell you, Thanksgiving of last year, I got a headache and it's never gone away. Particularly interesting patient, difficult to treat. There's also medication overuse headache, which is felt to occur when someone is taking abortive medications on a daily basis, or actually many headache specialists feel if you're taking it more than 3 days a week, you're at risk for having medication overuse headache, and that the headache is actually brought on by taking the medicine too much, and that if you stop the medication for 4 to 6 weeks, that the headaches would actually reduce in frequency. Another large area of headache is the post-traumatic headache, and that could be a whole topic in itself. People after a head injury can experience headaches. Usually it's for a few days at a time, but sometimes those can be long-lasting or even permanent after a head injury. The new daily persistent headache, we talked about abrupt onset within 3 days, lasts for at least 3 months. There's various things when they did research on these people, and basically it's 50-50 whether they hurt in the front of the head or the back of the head or everywhere, throbbing pain, pressure-like pain, nausea, yes, no. So it's the only thing that really characterizes it is this onset within 3 days and it never going away. I want to spend now a little bit of time talking about the pathophysiology of migraine. Migraine is generally felt to be an inherited disorder. We used to think that it was caused by vascular constriction, and indeed that's how they came up with the use of triptans. We knew that triptans caused vasoconstriction. Early research on migraine felt that the pain was due to vasodilatation. We thought, well, if we give somebody a drug that constricts their blood vessels, as soon as they get a migraine, maybe they won't ever go to the point of this throbbing, nauseating headache. And lo and behold, it worked. It wasn't until later that we found out that it probably didn't work the way we thought it was working. As a matter of fact, we don't really know how triptans work. Although they have a tendency to cause vasoconstriction, it doesn't appear that that's how they stop a migraine. We later found that someone had a migraine while they were undergoing a PET scan of the brain. And when they had their aura, which is a neurologic symptom that precedes the onset of the headache, they found that there was this cortical spreading depression going across the brain at the same time as the aura. Now, what does this mean? Well, a PET scan works by measuring glucose metabolism within tissues. And the cortical spreading depression means that its metabolism of glucose was decreased, and that gradually spread across the brain. It has nothing to do with feeling depressed or emotional depression at all. And it was just an interesting thing, and so then we thought it changed our whole idea of what a migraine was. That still hasn't cleared things up completely, so they're still working on that. Central sensitization, on the other hand, is something else we found out about migraine. And this is characterized by an increased spontaneous discharge rate among neurons in the brain and a reduction in the threshold of things that will stimulate a neuron, and increased responsiveness to both noxious and non-noxious peripheral stimuli, and an expanded receptive field. So what does all that mean? It means that the central nervous system, over the course of a migraine, becomes sensitized. And so that if you don't treat a migraine quickly enough, and you wait until this central sensitization has occurred, then the triptans don't work. Well, it's interesting because central sensitization has also been looked at from a number of other conditions, including chronic pain itself, and things like irritable bowel syndrome, and interstitial cystitis, and fibromyalgia. In all these conditions, there appears to be sensitization of the central nervous system with all these same characteristics. And so that has really informed our treatment of chronic difficult headache patients. And we'll get more into that as we go along here. This is just the International Headache Foundation, kind of the description of migraine. Neck pain is also reported by some patients as migraine specific, and that's something that we in our program, using a physical therapist, have found very useful, which isn't usually treated or addressed by a neurologist. And we also see these functional changes in pain processing within the brain among sensitized individuals with migraine. So all of these things, again, are kind of technical. I won't spend a lot of time on that, but inform our treatment of the difficult headache patients. So there have been a lot of randomized controlled trials in treating migraine. For chronic migraine, one of the things that's been looked at is Botox, or botulinum toxin A. It was found to be more effective than placebo in reducing monthly chronic migraine attacks by greater than 50%, with inconsistent improvement in quality of life. So some people said their life was better, others said, well, I'm not so sure. But this is compared to a placebo. And when you really break down, well, what does that mean? That means of 1,000 adults treated with Botox injections every 3 months, and they usually use 20 or 30 injections around the face and head and neck, only 170 would experience greater than 50% reduction in migraine, and 155 would experience adverse effects. 26 of them were bad enough that they would discontinue treatment. So, okay, it is better than placebo, but it's still most of the people aren't going to be benefited by 50% anyway with that. Topiramate did reduce disability but failed to reduce migraine frequency greater than 50%. Individual trials compared Botox with topiramate but found no real difference, so they both can decrease it, but it's not magic. Okay, so let's talk more practically now. The difficult headache patient. It's much more important to understand what kind of patient has the headache than it is to understand what kind of headache the patient has. That means it isn't as important to know whether this is a migraine or whether this is a tension headache. The only exception to that is if someone has a secondary headache. In other words, they have some other kind of problem. They have a brain tumor, say. They have had a stroke. They have a arterial venous malformation. They have an infection in their nervous system. Those things, it's more important to know that. But fortunately, those things are rather rare. There are certain red flags, but someone who has a chronic headache, they've had it for months or years, they've had it worked up before, it's no different than their usual headache, those patients are what we're talking about. Now, in the emergency room, you often see patients who have the worst headache of their life. They've never had headaches before. There's something different about this headache. They need a different approach. But when we're talking about a chronic headache patient, someone who has headaches nearly every day, now we need to turn our attention more to, okay, how is the patient reacting to this? What's going on in their life? And we can really look at this as more of a software problem than a hardware problem. And I think that concept may be useful. If you have a computer and you're putting your data in and you're getting funny answers, wrong answers, you have two choices. You can say, well, this computer's broken, I need a new computer. And if you get a new computer, but you put the same software in, and you get the same bad answers, and you go, oh, well, maybe it wasn't the computer, maybe it's the software. And our nervous system has both hardware components and software components. And the software components are how we think about our pain, how we've been taught or trained to react to certain things. It's not how we think about it, but how our nervous system has been trained to react to certain things. And that is often what's going on with people with bad headaches. You know, they'll often say, you know, well, I'm not any more stressed than anybody else I know. I don't know why I should get headaches. But they actually are stressing about their headache. And they get more upset by having a headache than other people would, or their reaction to it. And I'm guilty of this myself. I've had migraines my whole life. It wasn't until I learned to react to my migraine differently that I was able to get them under control. And that was learning to relax instead of allowing myself to get stressed by the migraine. It's something I had to learn how to do. All right, let's go on. Self-management is paramount, as with all chronic disease. If someone with diabetes, it's not usually that they don't know what they should do to manage their diabetes. It's just that they don't do it consistently enough, and so they're poorly managed. And really, this can be true of headaches as well. We often, as we work with patients, we find ways that we can relieve their headaches, and then they'll come in 2 weeks later and say, well, how are you doing with the headaches? Well, I had a real bad one yesterday. Well, tell me about yesterday. What did you do? And you find out that they didn't do any of the things that we know will help them get rid of their headache. And you go, well, why didn't you do that? Well, I don't know. I was too busy. I just took a pill. Okay, well, you need to be able to understand what it is that relieves your headaches, and you have to be willing to do it. So this is kind of what this slide talks about. You have to be able to self-monitor headache-relevant information. When you get one, stop and think. You're the detective here. Why am I having a headache now? I didn't have one yesterday. I didn't have one this morning. What happened? What am I doing differently? Then you need to have the specific behavioral management skills and problem-solving skills to say, oh, okay, well, that's what went on. And, you know, all of us are going to have days when the dog dies and we get fired and, you know, the car breaks down. And, of course, you have a headache on a day like that. Who wouldn't? That doesn't really bother most of us. What bothers people really is when they have a headache every day or day in and day out or multiple times a week. And the usual day gives us a headache. That's where we really need more help in getting these things under control. So then you need the motivation and confidence to use the skills in daily life. So you may know what to do, but you need to do it. So we do a lot of education about how our emotional reactions to the headache can make it better or worse. It's most common and natural to tense up when we're in pain, but it's the worst thing we can do when we have a headache. We set goals of treatment to manage headaches in such a way to maximize our functioning and prevent long-term complications and disability. If we set an unreasonable goal of never having another headache, that becomes very frustrating to people. And they take a passive approach. Well, I've taken the medicine, I still have headaches. You know, if they can be more interactive with what's going on and say, okay, I understand why I had more headaches this week. I need to be better about doing my stretches and doing my relaxation than I have been, but this week it got away from me. I can deal with that. Let me talk about our headache program at Mary Free Bed. So most headache clinics are run by neurologists, and they focus really on medications. And we started our program at Mary Free Bed because I was frustrated with sending patients off to specialty headache clinics and having come back on 12 different drugs and still having their headache. Or saying, yeah, I don't have a headache, but I can hardly function because I'm taking so much medication. And most people really don't like taking medication. So ours is a program which is almost an intervention. We have patients coming. We come for an initial evaluation. We make sure they're appropriate for the program, that they don't have any warning signs of secondary headache or any other problem that we wouldn't be able to address. And then we have them come for a 10-week program where they're coming twice a week, half an hour a week for physical therapy, focusing on posture and neck. And our physical therapists teach them their flare-up management techniques, what they do when they get a headache. And they kind of walk them through that stage by stage. The first thing you do when you get a headache is do this. The second thing you do is this. The third thing you do is that. If it hasn't worked, start over at the beginning and do it again. And then we have them see a pain psychologist. The pain psychologist is doing two things. One is educating them about their nervous system and how it works. And I'm going to have Dr. Litterdale talk to you more specifically about how they do that. And the second thing is using biofeedback to teach them how to relax, how to control that nervous system. We also do a kind of cognitive behavioral therapy, which is called ACT. That stands for Acceptance and Commitment Therapy. And that focuses on helping people manage their stress, you may say, or understand it better. And so then we do that for 10 weeks. And usually within the first 4 or 5 weeks, the patients are beginning to see the difference in the focus in our program from other treatments they've had. And usually by the end of a month, they're sold on it. If they come to the end of the month and say, I don't know, I'm having just as many headaches, I think you guys are crazy, I don't know what I'm doing here, we can usually agree that this approach isn't working. But fortunately, that's a minority of patients. Most of them are very happy with this kind of approach versus that of just getting more medications. And they begin to understand the whole headache problem that they're suffering from, rather than just trying to find a medicine that's going to cure them.
I guess I will cover this as this is Dr. Litterdale. We're moving into talking about the physiological effects of stress, and that's where the role of psychology really comes in. Dr. Hudson mentioned we do a lot of education of the client about exactly what is their nervous system taking in, and when they're having a headache, how does their nervous system alter. The autonomic nervous system really becomes dysregulated in a way that keeps people in a cycle where pain and sensitivity is often continues. So we take out an actual chart. We show them the parasympathetic and the sympathetic divisions of the nervous system, of the autonomic system, and go through all of the organs and different processes that are impacted. So, for example, with a headache, people I'll say, how many of you have to turn the lights down or go into a dark room or wear sunglasses when your headache gets really intense? And I'm able to educate them, that's because your pupils are dilated, and the more that the pupils are dilated, the more sensitive you are to the stimuli coming in. We go through the coldness in the extremities as the body prepares for the fight or flight mode. But with the headache or any kind of chronic pain, there is going to be no escape from that, so it just keeps it in a perpetual state of arousal. Going through digestive and issues, IBS, quite common in some of our patients, but we can find difficulties along all of the major systems, the liver, the gallbladder, really kind of explaining how the body is dumping all of its energy to activate the person into motion. But we're left with all those chemicals racing through our system and creating their own dysfunction and issue. So we really provide them with a thorough explanation of the autonomic system. And then we provide them with the hopeful message, which is it can be altered. We can intentionally take control of parts of our autonomic system. So one example is, again, putting the glasses on or turning the lights down sends that message to the nervous system, okay, there's not as much light coming in, maybe we're okay. Warming up the hands, warming up the feet, getting the extremities, changing the temperature of those extremities also sends a message back in because it's bidirectional. But the biggest part that we have control over in the autonomic system is our lungs. If we can control and regulate breathing and respiration, the heart rate will go in line unless there's another underlying issue. But once the heart rate decreases, then the other systems, the other organs also follow suit. So in essence, the person experiences relaxation, and then the cycle can be interrupted. And my experience in teaching people about their nervous system, because oftentimes we have very educated people who are type A personalities and very successful in life, and they look at me and they say, why did nobody ever explain that to me before? Or show me that picture or explain what was going on. they really seem to get it and buy in. So from that, I've already kind of explained why we're going to be doing some diaphragmatic breathing and relaxation. It helps to get their buy-in. Before I worked at the pain program, I would tell people, okay, you need to do some relaxation, and they would look at me and go, why? And I would explain it, but I didn't go into as much detail as we do with our patients here. So that really, I think, helps to get people's attention. The other thing that we do is we teach the diaphragmatic breathing based on the latest science. So again, if I were to tell somebody, okay, go do your relaxation, but they weren't doing it to achieve maximum benefit based on what we know scientifically, they could come back and say, I didn't notice anything. So we use biofeedback to begin with to kind of look at what a person's resting respiration rate is in our office. And then we educate them to where the rate is with a normal adult. And when they're stressed, it'll be increased. And then where we want to move it. So a relaxed, more rested kind of respiration rate is that 6 to 8 breaths per minute, and engaging the diaphragm. So that is a key component with people I work with. I overtrain them. I will have them go as low as they can go. Some people have gone to 3 to 4 breaths per minute, and then sometimes I have to wake them up. But to really get them to have that experience of what their body feels like as they take control of their breathing in that way. So if you could see me, I could visually give you this example of diaphragmatic breathing, of how to do it, how to teach your people to do it, but I will try to verbally walk you through it. It's very simple. So if you take your left hand and you put it on your chest over your heart, and you take your right hand and you find where your diaphragm is, somewhere between the rib cage and the belly button, and then you slowly breathe, and you can feel your diaphragm push out. I always joke with my female clients in particular that this is what women are not supposed to do. We're supposed to hold our stomachs in at all times, but in order to get the maximum relaxation response, we have to bring air way into the diaphragm, and then we have to release it, pushing it back out completely through the diaphragm and out the chest. While also that top hand that is on your heart is watching so that you're not over-breathing and you're not moving your chest too much. The diaphragm should be moving more. And you're not shrugging your shoulders or really getting your muscles tense in the process. So it really does take some practice to do effectively. The slide also says the emphasis is on the prolonged out-breath. That is also coming from research. You can have the in-breath. Used to teach square breathing, and that still kind of fits the model. So you breathe in for 4, and then you pause and you exhale for 4. So the longer prolonged out-breath is really what does it, really what triggers the nervous system to say, ooh, we're almost sleeping. It's activating the parasympathetic side of the autonomic system. So once we do that, on the diaphragmatic breathing, we're really building a mind-body connection, encouraging their awareness. My people who are like, I don't have time to do this all the time, I say do it before bed, and if you fall asleep, great. But then through the day, if you can remember once an hour to do 5 deliberate, intentional diaphragmatic breaths while you're sitting at your computer, it will begin to make it more automatic, and you can check in on that. And I have been amazed at people who come back and say, oh, after a week I was just doing it, and I noticed I was just doing it. I said, that's how habits are made. So we also teach other types of progressive relaxation strategies, including progressive muscle relaxation, the autogenic relaxation, body scan, and reinforce the posture training and stretches that our physical therapists have taught. So really giving our people more self-management skills and education. One of the things with some headache patients, I would be careful about recommending progressive muscle relaxation, or if they come back and say, oh, that was bad, just kind of steer them away from that, or tell them to not do the muscle tension and release from their neck upwards, because sometimes their muscle tension is too locked up and it will actually increase their headaches. until they're able to decrease the tension over time. So the psychological aspects of pain, if you were present for last week's webinar, went into a little bit more discussion about that. All pain is both emotional and psychological. And oftentimes, people with headaches will experience anxiety, kind of, when is my next headache coming? What if it gets in the way of me being able to go to that wedding? What if I can't do my presentation in 3 days? So there's a built-in anxiety process. Depression also comes along with loss of functional ability, or just kind of feeling like it takes up so much energy just to manage the headache or do tasks when the headache is present. As Dr. Hudson mentioned, interaction with thoughts is really key into kind of perpetuating the headache and the secondary pain that comes. We can think of, if I have a headache and I go, oh, this is awful, it's never going to go away, I'm focusing my attention on that, and most likely my body's going to respond with a lot of tension being held, kind of just bracing and then feeling down. But if I think, oh, my headache's here again, I'm noticing that my headache is here again, and what are the things that I can do, and how can I get to my self-management plan, or breathe and relax, and, oh, yes, my value is I'm going to go to that funeral, so I don't need to worry about it now, or to that wedding or that funeral. I don't need to worry about it now. When that moment comes, I'll see how I'm doing. So we're teaching, again, that mindfulness, that acceptance, and the being in the present moment. Again, we're increasing the willingness to experience physical pain sensations. So sometimes we'll talk with people about, have you ever done anything that you were really enjoying yourself and your daily headache was still present? And oftentimes they'll say, yeah, and they'll tell you the whole story, and it usually involves something they really enjoy and people that they really enjoy. And then go further with that and asking them, was your headache any different? And oftentimes they'll say no. So then that's the part where we can educate about the headache was still the same. You still would have told me it was a 10, but your attentional processes were focused on the moment, the things that you valued, the people that were there. So then that builds the seed in their mind that they can say, well, maybe if I do focus outward into my life, into things that are important to me, the headache won't be as big of an obstacle. It'll still be there, but it'll be in the background. And that speaks to the last point here with connecting with values-based living despite the ongoing pain. This slide provides some free resources for patients with technology the way that it is and the apps that are available on smartphones. We really have gone to using those often with our people. The two that are listed there, Breathe to Relax and Paced Breathing, are free apps. There's another one that we really use. It's called Stop, Think, and Breathe. And that app has guided meditations and relaxation exercises. The iTunes has a lot of podcasts. If you type in relaxation, diaphragmatic breathing, relaxation for chronic headaches, you're going to find a lot of resources available to people for free.
A lot of people, too, will tell you that there are certain triggers for their headaches. And one of them, one that I hear frequently, is weather. And we do have a lot of weather apps on our smartphones, but they don't control the weather. I know, I've tried. So unfortunately, that isn't going to solve that problem. And it's one of those areas where it's a frustration for patients, and I really try to get them not to focus on this idea that the weather causes their headache, because it can be kind of a self-fulfilling prophecy, and we really can't control the weather. So we try to get them to focus on things that they can control, and that's where a lot of the relaxation and the biofeedback comes in, is helping them understand that they can control more of this than they ever thought. The other thing is that I should try to contrast is between our approach and the typical medical approach. because Mary Free Bed is a rehabilitation hospital, we're used to working with people who have problems that there isn't a cure for. People with spinal cord injuries who are paralyzed, people with amputations, kids with cerebral palsy. None of them really want to have to live with those difficulties, but we don't have a cure for them. And so our focus is on rehabilitation in having them be the least disabled as possible and the most able to function independently as possible. Same thing with our headache patients. Even if we can't completely get rid of their headaches, if we can equip them to live with their headaches in a way that they're proud to live and they feel good about the lives that they're living, that becomes important. And a lot of patients, especially the very difficult patients, feel like they're not being a good mother to their children. They're not being a good employee at work. They're not being a good spouse because they always have these headaches. And when you begin to help them function despite their headaches, then it relieves that stress of feeling like they're not being the person that they want to be and they're not living their values, as Dr. Litterdale was saying. So for a case manager, how can you use this information? One way is to know that this resource of our headache program is out there, and a lot of people are unaware of our headache program. It is a different approach. We actually have a lot of the neurologists in the area that do send us patients because they see us as a resource that they don't provide in their office. I'm not aware of any other neurology office that provides the kind of pain psychology treatment that we have here. It's also different than the anesthesia-based pain clinics where a lot of people are sent, where their focus is either on medications or on invasive techniques such as occipital nerve blocks or other nerve-related treatments. Ours is very much non-interventional in terms of we're not giving injections, we're not doing infusions. We're really working with the patient and their response to their headaches and giving them tools that they can use on a daily basis. In helping also so you know about that and our program. Also, if you ever are dealing with patients who've been through our program, often having them say, well, if they're having problems, you have them on the phone, well, tell me what's going on. I know when you first finished the program, you were doing well. What has changed? Are you still doing your exercises? Have you gotten away from that? Has there been some other stress that has changed your situation right now? Do we need to get you back there? Those are all things that you can look at. The other thing that drives headaches, that actually sends people to the emergency room with their headaches, is when they kind of lose it over their headaches. They develop a higher level of anxiety. They feel like my head is killing me. It feels like my head's going to explode. They're catastrophizing and they're telling themselves these things. And that really turns up the pain of their headache. You want to do the opposite. You want to talk calmly. You want to not get, as a provider, not buy into their anxiety, but help them to calm themselves down. Educate them about what's going on. Get them talking. And often it's amazing how much when a patient can start talking about how they're feeling and their pain, that they do calm down. And then challenge them to use the tools that they have to get under control and do it again. And so those are all things that we do, and we see ourselves as critical in modeling those kinds of activities, those kinds of an attitude towards our patient.
And I would like to add to that too. In the process, sometimes we teach our patients that it's okay to accept that this is a really bad pain, headache day, and then to lower your expectations for self. So that, okay, you're in crisis mode about it today. Maybe you just need to kind of shut down, choose your battles, sleep on it, and then see how you're doing tomorrow. Just kind of that permission to relax, that permission to not freak out or catastrophize. Often we'll get somebody through that as well as listening to them talk about their pain, but it almost always results in somebody coming back the next day and going, okay, I'm back on track with my treatment plan, and it is a little bit better. But when they're in that crisis mode, they can't activate or perceive things accurately. I wanted to add that.
Great. I guess I would like to open things up to questions.
Okay. I'm going to take the phone off mute, so just so folks are aware, the phones will no longer be on mute. And then, Kristen, if there are any questions that came through the chat box, I'm not sure if we can see them, if you'll let us know that. So I'm going to unmute, so you'll hear the warning in just a minute.
All guests have been unmuted.
Okay, so the lines are open. Any questions in the chat box, Kristen?
There are no questions in the chat box at this time, Sue.
Okay, thank you. So
I see something at the bottom here. Despite your best efforts, there are times when you feel your patient's beginning to slip down that slope towards chronic pain. Okay. That I know that feeling. That it can be difficult to know when you're dealing with acute pain or chronic pain, but that's one of the things you have to try to figure out. If someone is having a severe headache and it's a new problem, those are the ones that may need to go to the emergency room. Even sometimes calling an ambulance if they have a sudden thunderclap onset of a severe headache they've never experienced before. Sometimes an ambulance is the appropriate thing. We're talking here mostly about chronic headache. Any other questions?
Does keeping a headache diary helpful for the provider?
It can be very helpful, yes, and it often is helpful for the patients as well. We actually treat a lot of adolescent patients in our program, and it's fascinating how many of the adolescents who are having problems with headaches in school and even missing school don't realize that they have the headaches. They begin Sunday night, and they usually don't have them after Thursday. They don't have them on weekends, on holidays, in the summertime. And often these are very good students. They may even be the best students in that the reason that they're such good students is that they worry so much. They worry about getting their homework done. They worry about getting good grades. And so then when they start getting headaches and missing school, that stresses them even more because they want to be in school. They want to be doing well. And the more headaches they have and the more time they miss from school, the more that stresses them and the more headaches they get. So, keeping a log can help identify some of that. There are other things that can happen with the log in terms of foods. There are certain foods for migraines nitrites and nitrates in prepared meats. Alcohol is a big trigger for migraines. And sometimes the MSG from Oriental food can be a problem.
And I would say that from a behavioral change or self-management standpoint, it's very useful to have people do a headache log, because when I use them in the psychology portion, I ask somebody to make note of, did they do their stretches, did they do their relaxation, and what other emotional triggers might have happened. And especially useful when they're moving from using those tools to cope with a headache versus going to the medication, because we're asking them to extend, okay, don't take your Topamax, or don't take your Tramadol, or, see how long you can go before you have to do a passive intervention using the skills that we're teaching. I think the headache log is very helpful in that way.
Okay. Do you see any correlation between menstrual cycle and onset of headaches?
Yes, migraine headaches are commonly associated with the menstrual cycle in women. We know that it is affected by hormonal changes. The problem is it hasn't really helped us all that much clinically. Most women will find that their migraines start around the onset of menses, and they get better at menopause. And they usually don't have them during pregnancy. But some women start getting them at menopause, and some women do get them when they're pregnant. And many women will get them when they're on birth control pills, and other women, when they're on birth controls, they don't get them. So there's not a standard hormonal treatment for migraine. Sometimes we can use the fact that women can predict when they're going to have a migraine and take some medications ahead of time on those days that will allow them not to get their migraines, or to modify their migraines so they're not as severe. But it has to be individualized.
You were talking about stretches. Do you have like a protocol of stretches, or is it just upper body, neck?
What we do is our physical therapists really are very experienced in treating headache patients. And we often see patients come in and say, well, I had physical therapy, it didn't really help, or it helped for a little while. So I think a standard off-the-shelf stretch for headaches is not always very helpful. Sometimes that will work, but what our physical therapists are able to do is to tell whether the tightness in the cervical spine is upper cervical or lower cervical, and whether they should be doing retractions and extensions or flexions and rotations, and that tends to be individual. And often patients have headaches which are one-sided, and it can be related to their neck, and they may have sometimes what's called a cervical derangement, and that, again, takes a trial and error approach of, let's try these stretches today. They come back in a week and say, man, that's the worst headache I've ever had. Okay, well, we better stop then. We've got to try the other stretch and finding out what's wrong. So I hesitate to say, well, just try this group of stretches, because it really depends on how the patient responds to them. That determines whether that was the right or the wrong stretch. If there's one, there's called a chin tuck or a cervical retraction. And you can probably look that up on the internet to find them. But again, that's kind of may or may not work.
Any other questions? I'm wondering, Dr. Hudson, Dr. Litterdale, So I think the research shows us, for the most part, a multidisciplinary approach is the most effective. And that, as we're trying to maybe knit some approaches together outside of that. Is that true, that a multidisciplinary team?
Well, the problem with the multidisciplinary approach in our clinic, frankly, is that it is pretty expensive and it takes significant time for the patient. So most headache patients don't need this much treatment. That's why I say most headache patients don't go to a doctor at all. But there are particularly difficult headache patients who may have been seen by their family doctor and put on a number of medications and it's not working, and may have been seen by a neurologist and been put on other medications or had Botox, or maybe they have gotten their migraines under control but they want to get pregnant and they don't want to be on some of the medications that they're on. And so there are instances where what the multidisciplinary approach, I think, offers something that the other approaches don't. I'm not advocating that this is something that everyone needs who has headaches, but the difficult headache patient who's having them very frequently, or it's significantly interfering with their ability to hold down a job or go to school, or it's interfering with their relationships, then this kind of a program, I think, offers something that our regular medical treatment doesn't. And I really enjoy working with these patients. I think we do a great job of often markedly reducing headaches. I've had a number of patients who told me that they've had headaches every day for 20 or more years, and come through our program and come back 2 months later and say, in 2 months I've had 2 headaches. I could never have believed that this could happen. Why didn't somebody send me here many years ago? And they were functioning with their headaches, but they were miserable.
I would add, too, that compared to the other programs that we treat in the pain program, the headache population seems to be the one that I'm often discharging early from pain psychology because they learn the skills, they buy in, and they practice them. So another option is the outpatient pain psychology through the pain center, where a person doesn't have to do the whole program but can have access to the pain psychologist. Usually we say 6 to 10 sessions. It's not as intense. And then if the referral to the full program seems warranted, that can be done also.
Well, we're close to the end of the hour, so we'll ask one more time. Any questions?
I guess one thing, too, if I can mention that if someone is overusing medications, that's the other instance that this program is really very good. That we have people who have gotten taking narcotic pain medications daily, or other medications daily, even the triptans every day. This carries significant health risks for them, and those patients also really need this kind of an approach.
Great. Well, I'd like
Dr.
to...
Hudson?
Yes.
I have a question in the chat box. Does insurance cover, such as Medicaid?
Medicaid has been an issue. Medicaid, up until January of this year, would only cover mental health professionals through community mental health. Now, Medicaid has changed in the last year, and now certain mental health professionals can be okayed by Medicaid and receive treatment. But our program has not received that yet. We are working on that. So Medicaid is an issue because of the fact that our programs are heavily rely on our psychologists, and Medicaid just does not allow that, or has not allowed that. Point. But the we have very good contracts with Priority Health and Blue Care Network, and we accept most insurances. And we are working with the Medicaid issue as well. But right now, we're not there with that one.
Okay. Well,
Dr. Hudson, does central sensitization occur with every type of headache, or are there only certain types where this occurs?
It probably, it doesn't depend so much. I mean, we know it occurs in migraine because it's been researched that way. I believe it occurs in many people, and not just headache, but with other pain syndromes. But it hasn't been as well researched as it has in migraine. So I think it does occur in other headache patients, and we see them that are, have the cold hands, have the high levels of adrenaline in their system. Their autonomic nervous system is on full-time arousal. And sometimes those things happen in people who've had a history of abuse or trauma in the past, and it may result in certain of those patients having severe headaches, but it can come out in different ways in different people.
All right. Well, we are at the hour, so I want to thank everyone that attended today. As a reminder, in order to receive your continued education credits, you will need to complete the evaluation and send that back, and then we can forward you the certificate. Thank you, Dr. Hudson and Dr. Litterdale. Really appreciate your spending the time today and making us more informed about headaches and options that are available and things that, as care managers, we can reinforce. Very helpful. And we have our next webinar coming up, and that'll be on the spine care. So if you haven't registered for that, that's out there available. You can go to our website at Mi-CCSI.org, www.Mi-CCSI.org, and registration information and details about that webinar available. So thank you, everyone, and hope you have a great afternoon.
You're welcome.